Module 2. Assessment and Treatment. There are two main guidelines discussed in this presentation. CRISM OUD National Guidelines released on March 2018 were written for all healthcare professionals with or without specialized experience in addiction treatment. The document Opioid Use Disorders, Diagnosis and Management in Primary Care from British Columbia was released on June 1, 2018. Both guidelines advocate and encourage initiation and maintenance care of OUD by primary care providers. Both guidelines advocate for pharmacotherapy as a first-line treatment. This has been shown to be superior to an abstinence-based approach. Guidelines acknowledge that access to psychosocial care may be a barrier in primary care. It is not mandatory but should be encouraged. This is because it may help to clarify underlying conditions and/or beliefs that contribute to OUD. Pharmacotherapeutic treatments include Buprenorphine and Naloxone, which is preferred, and Methadone. The items in italics are not discussed in detail as they are uncommon and require referral to a specialist, although not currently available from RODP. In summary, this presentation will focus on buprenorphine and naloxone rather than methadone. Initiation is possible with a PCP, however, maintenance of therapy may be more realistic with stabilized patients from RODP back to the community. A complete baseline assessment should be completed for every OUD patient. In the right-hand column, we see OUD-specific assessments. It's important to note the history of opioid use and which opioid is currently being used. For example, the use of fentanyl may indicate a higher tolerance and a higher dose of OAT needed. Previous OUD treatment may also guide treatment choices. This may determine the cause of previous treatment failures or adverse effects. On this slide, we see a list of commonly ordered labs. The RODP clinic may not order all of these labs at initial assessment depending on patient presentation and history. For example, if the patient is not IVDU, hepatitis and HIV serology may not be completed. If a patient is under the care of the RODP clinic and any concerning lab tests come up, for example, positive hepatitis or an STI panel, the patient will be advised to seek care from a PCP. PCP plays a role in management of comorbidities while patient is initiated or maintained on ODT from the RODP. If a patient presents with OUD, it should be treated with great urgency. It should be acknowledged that there is a high risk of death, viral disease transmission, and harm. Treatment exists along a continuum. We want to be able to intensify and de-intensify treatment as needed. This should be tailored to the patient's wants and/or needs. The approach should be a stepped and integrated care approach. If a patient fails one treatment option, another higher intensity treatment should be considered. Note that goals are not always abstinence. We should approach it from a view of harm reduction. For example, reduced opioid use is better than using 100% IV street drugs. This is the algorithm from CRISM and BCOUD guidelines. Harm reduction is the foundation of treatment. We should encourage all patients to adopt harm reduction practices. We should start with the lowest intensity treatment options, for example, withdrawal management. This may include pharmacologic agents to manage withdrawal symptoms, and it may or may not include psychosocial and residential treatment. Withdrawal symptoms typically include nausea, vomiting, diarrhea, drug craving, and extreme malaise. Although not truly life-threatening, it is often described as being so. Onset depends on the opioid or formulation of opioid being used. Short-acting opioids, like heroin and fentanyl, will have a faster onset and shorter duration of withdrawal. Longer-acting opioids, such as methadone, or sustained-release formulations of opioids, will have a later onset but will persist for longer. In this video, we see the perspective of the severity of withdrawal from a lived-in experience survivor.
Withdrawal for me was both physical and psychological. The physical part of the withdrawal would be, I felt like every single bone in my body was broken. I would have hot and cold sweats to the point where I couldn't put on clothes because I would soak through them. but I would freeze if I didn't. I would have diarrhea. I would be puking. There were so many different things. I would have anxiety to the point where I thought I was having a heart attack. I would have restless legs and arms, so I'd constantly feel the need to stretch my body out. But when I did, it was so painful because I felt like all my bones were broken. And it would make that restless leg syndrome and the pain worse and worse and worse as the days progressed. Psychological, depending on the day, let's say 1, 2, or 3, the voice in my head, which you would think would be working with you, was working against me. I would be trying to get clean, and I knew that if I made it through the 3rd or 4th day that I would be okay. But during that process, my mind would be telling me, like, you don't have to feel this way. You just have to get enough to not be sick. Just one bump, nobody's gonna know. You don't have to tell anybody, like, nobody's watching you do this. And so it was like my conscience was fighting against me. And so I was not just fighting against the physical, I was also fighting against my own brain. And so there was this very small piece of me that really wanted to get clean, but there was this huge part of me that was telling me I wasn't going to be able to.
As described in the video, stimulation of the reward pathway is associated with pleasurable human experiences. For example, the experiences we receive from consumption of food or sex. The same pathways work during opioid-associated euphoria. With opioids stimulating the reward pathway, we end up in a situation in which the pathway is downregulated and the person starts to experience tolerance. The new normal in the brain is only in the presence of opioids. Individuals are no longer able to experience euphoria or pleasure because of this downregulation and tolerance. Without opioids, the reward pathway is more difficult to stimulate. Individuals feel low during withdrawal due to minimal stimulation of the reward pathway in the absence of opioids. This results in a lower mood than normal, and the patient can experience depression, anxiety, and other psychological symptoms. Overall, managing withdrawal is challenging because it's extremely uncomfortable, and some of the symptoms are tied in with psychological, spiritual, and emotional symptoms. It makes it hard to persist through the full withdrawal period. There are 3 different assessment tools available. The SOWS and the COWS are the most common ones. The SOWS may be an easier assessment to complete as it relies solely on patient symptoms. No clinical parameters are actually measured. Either of these tools can be used during buprenorphine and naloxone induction. The score can indicate mild, moderate, or severe withdrawal. Withdrawal management alone is not recommended and is actually uncommon. There is substantial evidence showing increased rates of HIV, hepatitis C, and poisoning deaths compared to no treatment. This may be caused by withdrawal, reduced tolerance, and relapse, which is then associated with increased use of the drug and risky behaviors. If withdrawal management only is pursued, it should be done in an outpatient, community-based setting. In brief, inpatient withdrawals are not recommended. Withdrawal treatment should be followed with some ongoing addiction treatment, and this depends on the patient's preference. Withdrawal symptoms can be managed with pharmacological therapy. We may need to use these agents if withdrawal treatment only is chosen. We may need to use these agents to manage withdrawal during buprenorphine and naloxone induction. One of the most commonly used agents is an alpha-2 adrenergic agonist, clonidine. This can help to reduce the symptoms of withdrawal by opposing noradrenergic activity seen in opioid withdrawal. However, it will not reduce craving or malaise, and it's limited by the side effects of hypotension and sedation. It will commonly be used during the induction phase of buprenorphine and naloxone to get the patient to the first dose. Methadone and buprenorphine and naloxone for short-term management of withdrawal symptoms may be explored. Compared to clonidine, it will suppress withdrawal and cravings because it acts on opioid receptors. It is superior in retention and opioid abstinence in withdrawal-only treatment. Many other pharmacologic agents may be used to combat specific withdrawal symptoms. For example, diarrhea can be treated with loperamide. NSAIDs and acetaminophen can be used to treat muscle aches and pains. The American Society of Addiction Medicine suggests benzodiazepines as an adjunct option. However, because of their potential for addiction, and CNS depression in general, it may not be an ideal choice. Quetiapine may be a more common choice over the other options for insomnia treatment. Caution with QTC intervals should be considered if using with methadone. Any agent listed could be considered. The selection depends on the patient's medical conditions and what they have tried before. As mentioned previously, withdrawal management alone is not recommended. Some patients may pursue this despite the risks because they do not want long-term opioid agonist treatment. If pursued, it should be administered in a community outpatient-based approach. Avoid pursuing withdrawal management if it will last for less than 1 week. Patients should be advised on risks of subsequent relapse, for example, an increased risk of poisonings, hepatitis, and/or HIV transmission. Advise the patient on poisoning prevention strategies. For example, taking a test dose, not using alone, and not mixing with other drugs. After withdrawal management, these patients should be considered for long-term inpatient treatment or outpatient addiction services. This should not be the sole treatment. A common dangerous misconception is that OAT is not sobriety and that the patient is not actually getting clean. OAT is a mode of treatment. It's analogous to using insulin for diabetes, which is also a chronic medical condition that requires medication. As treatment intensity increases, we move to opioid agonist therapy. It is actually the most common therapy. Buprenorphine and Naloxone and Methadone are options. The currently preferred treatment is buprenorphine and Naloxone due to its safety profile and ease of administration. In this chart, we see a comparison between buprenorphine and Naloxone and Methadone. Methadone requires Health Canada exemptions for prescribing. This may not be realistic in community practice. Suboxone requires PCP to have TPP and the completion of a CPSA-approved training module. The 2 modules currently approved are one from the CAMH and one from the manufacturers of Suboxone. Methadone has higher treatment retention in individuals with higher intensity use, for example, intravenous drug users or those with a long history of addiction, compared to buprenorphine and Naloxone. Methadone is initially easier to start because the patient does not have to be in active withdrawal. Titration to the target dose is much slower due to the long half-life of methadone and because you have to manage its potential toxicity. CPSA also has strict guidelines on the frequency of dose escalations. Suboxone can be more difficult to start because the patient has to be in an active withdrawal state before starting this process, or it can result in a precipitated withdrawal. After the initial induction period, it can be rapidly titrated to the target dose because of its much shorter half-life compared to methadone. Methadone has a higher risk of poisoning because it is a full opioid agonist and can be combined with other opioids. Suboxone is often preferred because it is a partial agonist with a low risk of respiratory depression due to a ceiling effect. However, this effect may be lost if it is combined with other drugs such as ethanol or benzodiazepines. Buprenorphine and Naloxone is the preferred treatment to start with due to the safety profile and its ease of administration. If this treatment approach fails, it's easier to switch to methadone than vice versa. Overall, PCP are unlikely to prescribe methadone due to the regulation and difficulties with titration and dosing. This presentation focuses on the induction, maintenance, and follow-up buprenorphine and Naloxone treatment. Methadone is included here simply for a comprehensive presentation. It's unlikely that methadone will become commonplace in primary care. It is a full opioid agonist. It's generally well absorbed, but the absorption rate is slow. It's extremely lipophilic. It accumulates in liver and other tissues, and it has a long duration of action despite low plasma concentrations. It is metabolized by cytochrome P450 enzymes, primarily the 3A4 and 2B6 isoforms, to produce EDDP and other inactive metabolites. It has a very long elimination half-life. What is the clinical significance of its pharmacology? Well, because it is a full opioid agonist, this means it has a high risk of poisoning and or toxicity, it can be used with other opioids and may have a higher side effect profile. Due to its lipophilicity, it can be difficult to switch or discontinue. Methadone serum levels are not always indicative of methadone stores in fatty tissue. A patient may experience poisoning or toxicity due to unpredictable release from fatty tissue. There are, in addition, many drug interactions due to the metabolizing of the drug by CYP3A4 and 2B6 enzymes. Drugs that may have interactions with methadone due to the enzymes that metabolize both drugs are QTC prolonging drugs, benzodiazepines, antifungals, opioids, and alcohol. Because it is a full agonist, when methadone binds to mu opioid receptors, it fully activates the receptor. If a user is using an opioid IV, there will be peaks and troughs in the concentration of the drug in the plasma, with euphoria typically being felt at the peaks or the highest concentrations, and withdrawal being felt in the troughs or in the lowest concentrations. With methadone, due to it being administered orally or sublingually, the peaks and valleys are no longer present. This will prevent a concentration producing euphoria from being reached, and the lack of troughs will also prevent many of the withdrawal symptoms from occurring. In addition, due to its slow elimination kinetics, it has a long duration of action. This allows for once daily administration. The combination of buprenorphine and naloxone is currently the treatment of choice. There is a minimal risk of diversion, a smaller risk of respiratory depression, and it will compete with other opioids for binding at the mu opioid receptor. Unlike methadone, buprenorphine is a partial mu opioid agonist. The partial activation of the receptor is sufficient to reduce craving and withdrawal without full activation. This results in the ceiling effect. It can reduce craving and withdrawal, but will not stimulate mu opioid receptors to the point where respiratory depression occurs, even at full saturation of the receptors. The ceiling effect may be lost, however, if the user also uses benzodiazepines or alcohol. Buprenorphine displays high affinity at mu opioid receptors. It can compete with full agonists like fentanyl and morphine at the mu receptor, and it will significantly decrease the probability that they will be able to interact with the receptor. Because it interferes with the binding of other drugs in the system, it can result in a precipitated withdrawal. Commercial formulations of buprenorphine and naloxone combination comes in a 4-to-1 ratio. This slide indicates the way the buprenorphine and naloxone combination acts at mu opioid receptors. It is really the buprenorphine that is acting at the receptors, and it results in partial activation of them. Even with full saturation of mu opioid receptors, we will see a response that is still beneath the threshold that results in respiratory depression. Compare with the red line. This is what happens when a full opioid agonist like fentanyl interacts with the receptors. When sufficient doses are reached, all mu opioid receptors will be saturated. However, it activates the receptors completely, resulting in a very high response that exceeds the respiratory depression threshold. This is ultimately what results in poisonings and death. Even with very high doses and full saturation of the receptors, it is far less likely that buprenorphine combined with naloxone will result in respiratory depression and poisoning, again due to the ceiling effect. If buprenorphine is already bound to the receptors, the probability of another opioid having access and being able to bind to the mu opioid receptors is significantly reduced. Buprenorphine has a higher affinity, in other words, it binds more tightly to the receptor than other opioids. Therefore, introduction of other opioids into the system will result in a minimal response. In other words, the full opioid agonist really doesn't have a good opportunity to interact with the receptor. If patients are taking the buprenorphine and naloxone combination and they use fentanyl or other opioids, the effect of fentanyl is mitigated to the point where there's very little effect at all. This is because fentanyl is basically unable to bind to the receptor, and therefore the patient does not feel euphoria, but also there is little risk of poisoning. If an opioid is present and bound to the mu receptor, introduction of buprenorphine will result in competition for the mu receptor binding site. The ability of the full opioid agonist to interact with the receptor is significantly diminished in the presence of buprenorphine. This is because the affinity for buprenorphine at the receptor is much higher. As a result, there is a significant shift downwards in response. Initially, there will be a high response in the reward pathway due to the full opioid agonist interacting with the receptor. If a partial agonist with high affinity for the receptor is then subsequently introduced, it results in a rapid decrease in the response of the original drug. This will result in extremely uncomfortable symptoms in that patient. These symptoms are actually withdrawal symptoms. This is what we would call a precipitated withdrawal, and these symptoms will occur 30 to 60 minutes after the first buprenorphine and naloxone combination dose. As a result, ensure patients are in withdrawal, i.e. little to no opioid binding on mu opioid receptors, prior to initiating buprenorphine and naloxone therapy. Buprenorphine has poor bioavailability due to extensive first-pass metabolism. Its onset of effect is between 30 and 60 minutes. Note that plasma concentrations do not directly correlate with the dose. Buprenorphine takes between 3 and 7 days to reach a steady-state concentration. Therefore, it can take several days to see the full effect of buprenorphine treatment and to see if the original dose is sufficient. This drug is metabolized by CYP3A4 into a potentially pharmacologically active metabolite. It has an extensive half-life, but the effective half-life may be significantly shorter. The clinical significance of the pharmacology is as follows. We need to ensure that a patient is dissolving the sublingual tablets under their tongue. Oral administration is ineffective. Due to the metabolism by CYP3A4, it has significant drug interactions and a high risk of hepatotoxicity. Therefore, caution should be exerted in patients that have concurrent hepatitis or alcohol use disorders. LFT should be completed prior to initiating treatment, and frequent monitoring of high-risk patients is required. Naloxone is an antagonist at mu opioid receptors. When it binds to mu opioid receptors, it does not activate them, but rather prevents the binding of other opioids to this site. Naloxone is inactive if taken orally or sublingually due to its poor bioavailability. Naloxone is a component of Suboxone and is there as an abuse deterrent. However, naloxone is not responsible for precipitated withdrawal in patients who try to abuse the drug by using it IV. Typically, it's due to the relative affinities of buprenorphine versus other opioids that is the culprit for precipitated withdrawal. The symptoms often occur in minutes. On this slide, the induction protocol and follow-up is described on the right-hand side. The details can be found in the BC PCP guidelines or the CRISM guidelines. Induction is challenging for buprenorphine and naloxone due to the risk of precipitated withdrawal. It is analogous to food poisoning. If you get food poisoning from a specific food at a restaurant, you are unlikely to eat that particular food at that restaurant again. Similarly to buprenorphine and naloxone, if a patient gets precipitated withdrawal symptoms, it is extremely unpleasant and they are unlikely to want to try that treatment again. Patients should be in active withdrawal, minimally moderate withdrawal with COW and or SOWS scores. If there is any doubt, delay the first dose. Patients should be in active withdrawal, a minimally moderate withdrawal with a COWS and or SOWS score. If there is any doubt, delay the first dose. It would be better for a patient to be in withdrawal for longer than to cause a precipitated withdrawal. Developing a working relationship with a community pharmacist can be useful. They can help with withdrawal assessment, dose administration, and follow-up during the critical initial days of induction. Patients transferring from the RODP clinic will have completed induction and be stabilized on a dose. Buprenorphine and naloxone should be titrated to the target dose within the first week of treatment. Titration is not based on any lab values, but rather patient symptoms, such as craving or feelings of withdrawal symptoms. If a patient continues to use, they will not have the effect of other opioids due to the binding affinity of buprenorphine at mu opioid receptors. This may be indicative of inadequate dosing and an inability to suppress cravings. A dose increase may be required. Buprenorphine and naloxone induction is more complicated in the beginning due to the patient being in active withdrawal, but titration to optimal dose is much faster than with methadone. The START trial looked at buprenorphine and naloxone in combination versus methadone with respect to its impact on liver damage. It was a randomized controlled trial. It included patients diagnosed with OUD under DSM criteria. Participants were primarily male, white, and heroin users. Buprenorphine and naloxone induction dosing is different than what is currently recommended by CAMH or BC guidelines. It started with 2 to 8 milligrams with a maximum of 16 milligrams, in contrast with 12 milligrams for a daily max in other guidelines. The max on the second day and onwards was 32 milligrams. The dose was titrated in response to withdrawal symptoms, opioid use, or craving. The study looked for ALT and AST elevations, and the patients were followed for 24 weeks and up to as many as 32 weeks. The trial showed that there were differences in ALT and AST elevation between buprenorphine and naloxone and the methadone group. The implication is that it may be safe to initiate buprenorphine and naloxone at higher initial doses with minimal risk of liver dysfunction. Using a rapid induction approach, i.e. targeting 16 milligrams on day 1, 24 milligrams on day 2, and titrating up to a target dose on day 3 and onwards, may be considered. It appears to be safe, there is a low risk of liver toxicity, and it may be better for patients as it is more cost-effective and time-effective, and the patient will reach the target dose more rapidly. This is the current practice at the RODP clinic. Proper buprenorphine and naloxone administration is essential for efficacy. Swallowing sublingual tablets will result in zero efficacy. Community pharmacists may witness ingestion and act as safeguards for appropriate drug administration. Counseling patients to expect a longer dissolution time, up to 10 minutes, is important. A patient cannot swallow during dissolution, so saliva may accumulate in the mouth, and this may make them feel uncomfortable. Other forms of buprenorphine combined with naloxone are available in the USA. Currently, generic and brand name sublingual tablets are available and covered in Alberta.